and in Parkinsonism and Dementia. As we all know, Parkinsonism and dementia are among the most challenging and neurodegenerative conditions seen in the elderly patients. Early and accurate diagnosis is the key to better management, prognosis, and quality of life. In this context, DaT scan, a dopamine transporter imaging technique, has emerged as a valuable diagnostic tool in differentiating Parkinsonian syndromes and dementia subtypes. These academic sessions aims to enhance our clinical understanding, bridge the gap between neurology and geriatrics, and encourage evidence-based practice in neurodegenerative disorders. We are privileged to have with us eminent dignitaries, distinguished faculties who make this event truly special. To begin with, I request Dr. Anand Ambali sir, Professor and Head Department of Geriatrics, to kindly escort our chief guest, Dr. Rajesh Honnutagi sir, and our guest faculty, Dr. Rakesh Sajjan sir, to the dais. I now invite Dr. Mohammad Abrar sir, Assistant Professor, Department of Geriatrics, to welcome the gathering.
Good evening, one and all present here. Mahatma Gandhi ji has rightly said, live as if you are to die tomorrow, learn as if you are to live forever. On this note, it gives me immense pleasure to welcome you all to this guest lecture on Role of DaT Scan in Parkinsonism and Dementia. Firstly, I would like to extend warm welcome to our guest faculty, Dr. Rakesh Sajjan sir, Consultant Nuclear Medicine Physician, Central Manchester University Hospital, NHS Foundation Trust, Manchester, United Kingdom, who is kind enough to agree on giving this guest lecture. I'd also like to welcome Dr. Rajesh Honnutagi sir, Professor of Medicine and Medical Superintendent, BLDE Deemed University, Sri B. M. Patil Medical College Hospital and Research Center, Vijayapura, who kindly accepted our invitation to be the chief guest of this program. Next, I would like to welcome Dr. S. N. Bentoor sir, Professor and Head, Department of Medicine, and Dr. Sangamesh Bhagavathi sir, Associate Professor and Consultant Neurologist, as chairpersons of this guest lecture. I would also like to welcome our Chief Patron, Sri B. M. Patil sir, Honorable Chancellor, and patrons, Dr. Y. M. Jayaraj sir, Honorable Pro-Chancellor, BLDE Deemed University, and Dr. Arun C. Inamdar sir, Honorable Vice Chancellor, BLDE Deemed University, and advisors, Dr. R.V. Kulkarni sir, Registrar, BLDE Deemed University, and Dr. Tejaswini Vallabh ma'am, Principal, Dean, Faculty of Medicine, BLDE Deemed University, Sri B. M. Patil Medical College Hospital and Research Center, Vijayapura, to this guest lecture.
Name kar raha hu, ruk jao.
I would also like to welcome Dr. O.P. Sharma sir, Secretary General, Geriatric Society of India, and Dr. Atul Kulshrestha sir, President, Geriatric Society of India, to this guest lecture. I would also like to welcome honored guest, Dr. Sangram Biradar sir, Governing Council Member, National API, and Dr. Ravi Kirti sir, Governing Council Member, National API, to this guest lecture. I would also like to welcome Dr. B. Mahalingappa, Chairman, API Karnataka Chapter, and Dr. Mohan Kumar M., Secretary, API Karnataka Chapter, to this guest lecture. I would also like to welcome Dr. S.L. Chandargi, Chairman, API Vijayapura, and Dr. L.S. Patil, Secretary, API Vijayapura, to this guest lecture. Lastly, I would like to welcome Dr. Anand P. Ambali sir, Professor and Head, Department of Geriatrics, and other faculty members from various departments. Sit back, relax, and enjoy this academic feast. Once again, welcome you all to this guest lecture. Thank you.
Thank you, sir. To invoke divine blessings for today's program, I invite our interns, Dr. Inisha and Dr. Ritu, to present the invocation song.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुर्मदेव सर्वकार्येषु सर्वदा.
Thank you, Rinisha and Ritu. I now invite Dr. Bhupati Tabasum to introduce our distinguished guest faculty, Dr. Rakesh Sajjan, sir.
Good evening, everyone. It is my great honor to introduce Dr. Rakesh Sajjan, sir, an accomplished consultant nuclear medicine physician at Manchester University Hospital, NHS Foundation Trust, Manchester, United Kingdom. Dr. Rakesh Sajjan, sir, has completed his MBBS from BLDE Sri B. M. Patil Medical College in year 1998 and has obtained his MRCP in 2010 and has earned his MSc in Nuclear Medicine Science. In Nuclear Medicine Science and Practice with merit from King's College London in 2013. He received his certificate of eligibility for specialist registration in nuclear medicine from University College London Hospital in 2015. Since 2015, Sir has served as a consultant nuclear medicine physician, leading PET CT services in oncology, pediatric nuclear medicine, F-DOPA PET imaging for congenital hyperinsulinism. He has also been actively involved in national professional leadership as the BNMS representative for Northwest of England and previously as the specialty advisor for nuclear medicine from 2019 to 2024. Dr. Rakesh Sajjan, sir, academic contributions are highly commendable. He has a record of 6 full peer-reviewed journal papers, 7 book chapters in leading international publications, 11 case reports in reputed medical journals, 15 conference presentations at major international meetings. Dr. Rakesh Sajjan, sir, has presented his work at renowned international conferences, including Society of Nuclear Medicine and Molecular Imaging meetings in USA and Canada. Beyond clinical and academic excellence, Dr. Rakesh Sajjan, sir, is also an educational supervisor and mentor for nuclear medicine trainees, MSc students, and technologists in UK. His leadership and commitment to quality improvement have made a lasting impact on both patient care and postgraduate medical education. Today, we are privileged to have him here among us to share this expertise on topic that holds immense clinical importance, the role of DaT Scan in Parkinsonism and Dementia. Please join me in giving a warm welcome to Dr. Rakesh Sajjan.
Thank you, Tabasum. I now request Dr. Varad sir to present sweets to our guest faculty and chief guest as a gesture of gratitude and affection. I now invite the chairpersons for today's program, Dr. S.N. Bentoor sir and Dr. Sangamesh Bhagavathi sir, to chair the session. We will now begin with the most awaited part of today's program, the guest lecture by Dr. Rakesh Sajjan sir on role of DaT Scan in Parkinsonism and Dementia. Over to you.
क्यों मैं से क्या है यार
Thank you for the lovely introduction.
काफी है ना तर तीन 2 दिवसात कळेल ना
Thank you for the introduction, and dear Dr. Ambali sir, Dr. Honnutagi sir, Dr. Bhagavathi, Dr. Bentoor sir, all the professors and my colleagues and dear students. It's always a pleasure to come here and share the knowledge. This is my third or fourth lecture. So today's topic is the role of DaT Scan in Parkinsonism. So the objective of this lecture is to understand the spectrum of Parkinsonism, its pathophysiology. That is quite important to understand how the DaT scan works. How does different imaging modalities help as a problem solving tools? And to give a brief knowledge of what DaT scan is, the scanning protocol and image interpretation. And then lastly, I've got a few slides to about artifacts and variants. I hope I'm audible to everyone, including the online audience. So if you have any doubts or questions, you can always stop me, or there is a bit of time at the end of the lecture, you can ask the questions then. So what is Parkinsonism? So as you all know, it's a neurodegenerative condition causing Parkinson's disease and Parkinson's plus syndromes, such as multiple system atrophy, progressive supranuclear palsy, corticobasal degeneration, and dementia with Lewy bodies. Now, when I say dementia, my concentration mostly will be on Lewy body dementia and corticobasal degeneration. So what are the mimics of Parkinsonism? The other causes which can have extrapyramidal symptoms are vascular Parkinsonism, drug-induced Parkinsonism, and benign essential tremors, which can mimic like Parkinson's. So what is the incidence of Parkinson's disease? So mainly I'm going to look at the data compared to Western countries. So if you see, it's about 12 to 25 per 100,000 people, whereas in Asia it is 5 to 12. So literally almost half of the Western country if you compare. And the estimated global incidence is 10 to 18 new cases per 100,000 people per year. And it's been estimated that number of patients with Parkinson's worldwide would be 25 million by 2050. So to understand a little bit about the imaging, we need to know about dopamine, what it does, especially we have very young students. So the dopamine is a neurotransmitter which modulates cognition, attention, and it's a center for reward and also motor activity. So any hindrance to dopamine signaling leads to neurodegenerative disease and cognitive problems. So the pathology, mainly it affects the substantia nigra, which is the region in the brain, which is critical for motor control and also emotion. The loss of dopamine producing neurons and accumulation of abnormal proteins such as in Lewy body causes, that's the main reason for the extrapyramidal symptoms in Parkinsonism. So what are we imaging in DaT scan? So this is an important slide to look at. So the amino acid L-tyrosine is converted into L-dopa and then subsequently dopamine. And then it gets stored in the vesicles in the pre-synaptic end of the neuron. And then once it is excited, it gets transported into the synaptic cleft. Now, if you see, that's the dopamine transporter. Now, this is what we'll be imaging. So this imaging is particularly for the presynaptic dopamine transporter. So any condition which affects dopamine transporter will cause the abnormal scan. So we'll go through what are the conditions where you can get where the dopamine transporter gets affected. So is there any gold standard test for Parkinsonism? It's a difficult question to answer, but can CT be a gold standard or MR? These two modalities are used to rule out other causes rather than diagnosing the Parkinsonism. Again, DaT scan doesn't diagnose it, but it supports the clinical diagnosis. So the gold standard test, there is no gold standard test. The diagnosis is based on clinical evaluation, on history, examination. So it's a purely clinical diagnosis. Any test which is the sensitivity or specificity is all based on in comparison to the clinical diagnosis. So assuming the clinical diagnosis is the gold standard in Parkinson's disease, the sensitivity ranges between 79 to 100%, and the specificity is reported as 97 to 98%. So as you can see, the specificity is very high. So it's about 97 to 98%. So if the scan is abnormal, the probability of the clinical diagnosis being correct is 97% to 98%. So this is another paper which compares the pre-scanned diagnosis with that of following the scan. So again, as I said, the scan only supports the clinical diagnosis rather than the scan itself is a diagnostic test. So you can see here the Parkinson's disease, the pre-scan diagnosis compared to the percentage of patients retaining initial diagnosis, it's about 89.3%, so 90%. So that goes with the, it's quite sensitive. Similarly, if you look at Parkinson's plus, 68% had retained the diagnosis following the preclinical diagnosis. So overall, the sensitivity is about 92%. Specificity again is quite high, 95%. And the overall accuracy rate is 93%. So the main indication is to differentiate Parkinsonian syndrome from essential tremor, drug-induced Parkinsonism, and vascular Parkinsonism. So that's the most common indication we get when we get these scans. It can also be used as an adjuvant for other diagnostic evaluation, for example, differentiating between Alzheimer's disease from Lewy body dementia. Now, the DaT scan will not differentiate between idiopathic Parkinson's disease and Parkinson's syndromes, because if you remember, the mechanism or the pathophysiology is the same for all these conditions. So it's all presynaptic dopamine transporter problems. So you can't differentiate the different types of Parkinson syndrome. So I think we have already gone through this dopamine transporter. So what do we use to for the DaT scan? So there are many radio tracers which are available. One which we are interested is called ioflupine. So this is iodine 123 ioflupine. This is what we are going to discuss further. There are some tracers which also look at post-synaptic receptor imaging. These are not commonly done. I haven't seen one, but this is the most common tracer which is used worldwide. So what is iodine 123 ioflupine? So iodine 123 is the radioactive substance to which you then bind the ioflupine. And that gives you iodine 123 ioflupine. So the commercial name is DaT Scan, which is abundantly produced by GE company. I think it is the main company which produces a DaT Scan tracer and supplies worldwide. The half-life of iodine 123 is 13 hours. The energy, gamma energy from I123 is 159 keV. Now, in most of the nuclear medicine studies, the energy level is 140 keV, whereas the iodine 123, it has got slightly higher energy. So this makes a difference when you choose the collimator. Collimator is which detects the gamma rays coming from the emitted from the patients. So you need a high energy collimator in order to image DaT scan. Whereas if you do renogram or bone scans, you need a low energy collimator. So activity we give is between 110 to 250 megabecquerels. Now, there is a bit of patient preparation. So we have a dedicated team which contacts the patient and then prepare the patient for the scan. Now, thyroid blockade. What is thyroid blockade? Since we are using, sorry. Sorry, I didn't know if there was a question. If there is no question, then I'll continue. Okay, so thyroid blockade, the main reason for thyroid blockade is iodine 123 is, the thyroid is, takes up the iodine. So if thyroid takes up radioactive iodine, there is a lot of radiation to the thyroid gland. So in order to minimize the radiation to the thyroid, we have to block the thyroid with the cold iodine. So by giving cold iodine, you can block the thyroid. The radioactive iodine will not go to the thyroid. So it does go in a very small quantity, but it doesn't harm the thyroid gland itself. We have to check the medications which may interfere with DaT binding. It's very important because about 5% you can get a false negative or a false positive scans. So you need to be aware of what medications can cause false positive or negative results. And we also ask the patient whether they can keep still for 30 to 40 minutes. Now you can imagine how difficult it can be for a Parkinson patient to keep still for 30 or 40 minutes. Now, a lot of the referrals we get, they are mostly like early onset Parkinson. So it's not that difficult for us to do the scan. But there are some patients where they have severe tremors where we could not do the scan because they couldn't keep still. The history of incontinence, that is also very important because once we give radioactive iodine. It's then excreted through the kidney as well. So if they are incontinent, camera gets contaminated. So the subsequent, you can't use that camera rest of the day. So it's quite important to know that history so that you can take precautions much earlier. And patients who are claustrophobic, it's again difficult to do the scan. If somebody says they are claustrophobic, what we do is we bring the patients first. Before injecting, we run a trial on the camera. And once we run the trial and patient is able to tolerate, then only we inject the radiotracer. Otherwise, we don't. So what are the medications that would interfere with that? So these are the list of medications which have high affinity for DaT. So if patients who are taking these medications are given the tracer, tracer will not take up because of these medications which have got high affinity to the dopamine transporter. So one of the common medication is it's not medicinal use. This is mostly used as a recreational drug, cocaine. Now you will be surprised to know we take that history even if patient is 70-year-old or 75-year-old. Don't hesitate to ask that question, especially in Western countries if you are doing this, because a lot of some of patients, we do see them taking cocaine. So if you do the scan in them, then the chances of getting falsely positive scan is quite high. So it's you must take the history and make sure they're not on medications which might interfere with the uptake. Now, if they are on medication, depending on the half-life of each medication, we ask them to stop the medication for 5 half-lives. Now, as you can see, most of these are rarely used, so it's not a problem. Whereas those which increase the striatal binding, which are the majority of them are SSRIs. So if they are on SSRIs, we ask them to again stop it for 5 half-lives. What happens if you don't stop them? There are some medication which the SPC mentions that you don't need to stop. It doesn't interfere with visual interpretation. So where possible, you can stop it. If not, you can still carry on with the scan. So one of the common medication is the sertraline. If they are on sertraline, recommendation is to stop. But if you can't, you can still continue to do the scan. But you need to be aware of the medication when you report the scan. So the protocol, we give potassium iodide, 130 milligram, 1 hour before the scan. So patient comes around 8:30, and then we give them medication. 1 hour later, we inject with DaT scan, ioflupine. So it's a slow IV injection followed by saline flush. How slow? Between 1 to 2 minutes. It's quite irritative if there is a small vein. Patients do complain when you are injecting. They do feel it. So we prefer slightly prominent vein rather than very, very small vein. You can still inject slowly without any problem. After the injection, patient have to wait for at least 3 hours before we start the scan. And the SPECT scanning takes about 30 to 45 minutes. And it is important to keep still during the scan. So suppose if patient, say, moves at 29 minutes before the scan is completed, then you cannot reconstruct that. Then you have to repeat the scan. So we do take measures to try and see minimize that the movement during the scan. So as you can see in the image, how close the camera is to the face. And those who are claustrophobic will not tolerate the scan. So this two big gamma heads, so there are two heads here, and it can be daunting to the patients, especially if they have some cognition problems. They will not stay there. So we have to have all that information before you start doing the scan. Sometimes we have to put a strap on the head. Again, with the patient consent, we put a strap and then image. If you want, if some patient may prefer to have blinders to their eyes, so that it's not too daunting for them, because you can see such a big head, the camera head. Patients really struggle if they keep their eye open. Some patients keep their eyes closed. So it literally comes within inches to the nose. So let's look at some of the examples, how once we finish the scan, it comes for processing. So once we process the images, this is what we get. So this is a normal scan where you can see two comma shape. So that's the caudate nucleus, and then you have putamen. The tail bit is the putamen. So that's the striatum. So right and left striatum. Now, abnormal scan, anything you lose the signal, for example, putamen on one side, putamen on both sides, or caudate nuclei on one or both sides. That's abnormal scan. So this is typical normal scan. You can also see the background activity in the brain. It is very less. Okay, so and we'll see some of the abnormal scans. So as I said, loss of comma shape on one side, or loss of comma shape on both sides, both reduction in both putamen and caudate nuclei. So those are all abnormal scans. Now, sometimes it is also very difficult to come to a conclusion when you are reading these scans. So that's when we use the semi-quantification software. So we use a software called DaT Quant, which helps or support our visual diagnosis, so the visual interpretation. So we'll see some of the examples. Now, there is another condition where you can see the balanced loss. This can appear as normal, but actually it is not. You can only know when we do the quantification on these balanced ones. So this is case number 1. All these patients whom I'm showing, they are all 60 years of age or above. So I will, where the patients are young, I have put the age there. So this is the first patient with clinical indication of evaluation of tremor. Previous DaT scan was indeterminate. So what we can see here, again, two comma shape. So we are seeing the caudate nuclei very well, and then we are seeing the putamen very well. Not much of increased background activity. So if this is interpreted visually, we will say it is normal. And which it is if we see the quantification. So we did the quantification to make sure we are not dealing with the balanced loss here. So that's the quantification DaT quant we use. So the chart you're seeing here, that's the normal population. So the DaT scans, all these dots which are falling are within the 2 standard deviation. So anything which falls below this line, they are considered as abnormal. So which is -2. We are looking at it's very similar to DEXA scan, where you look at a standard deviation. So this red dot is what is where the patient is falling. So it's very well within the normal limits. So here the patient was on sertraline. So whether sertraline caused this normal uptake, because from an abnormal scan, you can't have a normal scan. Either it deteriorates or remains the same. So according to the history, patient had indeterminate scan in the past, and there was some reduced uptake in the protamine. Currently, there is no reduction at all. So probably the medication explains why this is completely normal. This is the second case, Parkinson's disease, to investigate the mental decline. I'm sorry, forgot to take the name. So as you can see, the patient is struggling to wash, dress, and look after herself. So they were investigating for other organic causes. Now, I think you have all seen the normal scan. You probably are able to say whether it is normal or abnormal scan. So as you can see, there is loss of protamine, both sides. You're seeing 2 dots, which are only the caudate. Now, probably the caudate nuclei also show reduced uptake. That we'll know when we do the quantification. And if you look at the background activity in the brain, that is increased. Normally, you should not have any increased background activity. So markedly reduced activity in the protamine bilaterally with increased background activity. So this is the quantification. And here you can see where the patient is falling. So it's well below these two standard deviation, below this line. So both the striatum, right and left, is very abnormal. So this is in keeping with Parkinson's syndrome. Now, as I said, we cannot differentiate Parkinson's disease from Parkinson's syndrome. So the way we give the report is we mention both, so in keeping with the Parkinson's disease or Parkinson's syndrome. And that may have also include the, this patient already has got some cognitive impairment. The patient may even have Lewy body dementia. And typically, protamine are the first one which lose the function, followed by the caudate nuclei. So you always see, you don't see a patient where caudate nuclei are not there and protamine being present. So it is always the protamine which goes first. This is case number 3, a very disabled patient with slow movements. Probably functional, they thought, but need to exclude Parkinsonism. Patient had a long COVID in 2020. Since then, progressively slower movement. This is a nice case. So again, you can see here the comma shape is preserved, both sides. But one abnormality we are seeing here is the increased background activity, which you should not be seeing in patients with normal DaT scan. So this, you probably now got the idea. This is probably a balanced loss. So on visual analysis, there is symmetrical tracer uptake in both caudate and protamine bilaterally. But there is background activity, increased background activity. And you can see here, the semi-quantification is quite abnormal. And you're seeing this dot here, which is below the 2 standard deviation. So again, this is a balanced loss, suggestive of Parkinson's syndrome. This is a very young patient, which we did about a couple of months ago, presented with unilateral Parkinson's symptoms, very atypical. And their question was, could this be Parkinson's disease or corticobasal degeneration? So as you can see, this is the scan. Now you can see the caudate nuclei, but the putamen are very short. So there is loss of putamen tail if you see carefully. And also there is a slight increase in the background activity. So clearly this is an abnormal scan. So that's the quantification in that patient. And you can see it's quite below the 2 standard deviation. So it's very abnormal scan in a 40-year-old. Now, as we said before, we cannot differentiate the Parkinson's disease from the Parkinson's plus syndrome. So here, again, whether it is CBD or PD, we cannot tell. All we can say is there is an impairment in the presynaptic transporter mechanism. So, but usually CBD from the experience, it's thought to be less likely in this patient due to bilateral involvement. Although you can still see that in CBD as well. So I think what we have given the answer about that there is an impairment in the dopaminergic transporter mechanism. The treatment, I think, remains almost similar in PD and CBD. So at least we have answered the question. This is 69-year-old, again, with Parkinson's syndrome, with cognitive decline. A very abnormal scan, you'll see you don't need quantification for these kind of patients. You can see very high background activity and loss of putamen completely, and there is some uptake in the caudate, but that is also severely reduced. So this is an abnormal scan in keeping with Parkinson's syndrome. Now, again, we have to be careful here. We cannot distinguish the 2 caudate. So it's kind of mixed here. Sometimes that you can see in movement, patient movement. So I'll show you an example at the end. So this is just an example to show how DaT scan differs from the other structures. So it's the same patient where patient had a FDG PET-CT, which is this one. And you can see the caudate and the putamen very clearly with no abnormality. And the same thing goes with the MR. So patient had a FDG PET MR. So it's completely normal, whereas DaT scan is grossly abnormal. So just to show a few examples of variants and artifacts, because these can mimic Parkinson's. So it is important to be aware in order to not to give a false report. So you can see here the patient with the head being very straight. You have symmetrical uptake in both striata. Whereas here you can see the patient head is tilted. So if the patient head is tilted, the scan may appear like an abnormal scan, but it is not. And if you see here, the right stratum doesn't appear. It appears late and then it disappears late. So that indicates the patient is tilted. It's not an abnormal scan. It is a normal scan. This is a movement artifact. If patient is moving, this is how you will see. And you can see here the chordate should be separate, whereas here you're seeing the chordate being joined together. This is sometimes called kissing chordate, which is very typical for movement artifact. Again, is there a way to tell this is normal or abnormal? It's very difficult to tell unless you repeat the scan. So one more example of an attenuation artifact. So as the iodine 1,2,3-ioflupine also goes to the salivary glands, if we include the salivary glands in the processing, that will cause attenuation artifact. As you can see in the slide here, there is no uptake in the stratum. So this may appear as an abnormal scan, but it is not. That's because we have taken the salivary glands when we were processing the scan. So it's important that you exclude salivary glands when you process to avoid any attenuation artifact. And one of the other causes of very low uptake, for example, if you see this scan can be an abnormal scan. And sometimes the partial tissuing of the tracer can also give such appearance. So this is just a summary slide where you can see the normal scan with normal ratios. Sometimes you can have balanced loss. You have to be careful. So the quantification is quite useful here in balanced loss. If it is a unilateral reduction in putamen, you need to exclude other causes such as vascular cause. So the stroke in the stratum can mimic the Parkinsonism. That's where your CT and MR becomes very useful. And of course, if it is abnormal, you will see this is another pattern of full stop, and the other pattern where you see diffusely increased background activity with reduced uptake in the stratum. And that's my last slide. So they are my colleagues who work with me who have contributed to the some of the slides I have shown you. Thank you very much. So if you have any questions, please do let me know. Yes. No, it cannot differentiate between the plus syndromes and even from Parkinson's disease. So it can be used as an adjuvant for differentiating from other types of dementia, but it can't differentiate the plus syndromes. Yeah. No, because it's a very small amount of radiation. Because thyroid is a bit more sensitive, we do get patients where sometimes they do forget to take the medicine or they are allergic to that medication. We still carry on doing the scan. The risk is low. The RSAC committee advises us to expose anyone if you keep the exposure to a minimum. So that is the aim. It doesn't harm the patients. It's a repeated exposures which can have a cumulative effect. Single exposure will not harm. And it also gets excreted via the kidney. So it decays and it gets excreted. So radiation burden is quite low. We do use this often, so we accumulate patients. So we do once weekly. 1 day a week, we do about 3 to 4 scans in a week. That's our average. Sometime we cannot, because it takes a longer time to prepare the patient. If we get complicated patients, we allow double time on the camera, so we do a bit less on that particular day. But on an average, 3 to 4 scans a week.
I just want to ask a question.
Yes, sir.
Yeah.
Professor Ambali, am I permitted?
Please go ahead, sir.
Well, I must say, a wonderful talk about and in fact, a lot of learning because of your lecture, Dr. Rakesh, Professor Rakesh. I just want to ask you a question. Suppose a case of Parkinson with cognitive decline, they develop some kind of abnormality in the physical examination. Do you repeat the scan, or is there any indication for repeat the scan to see whether the disease is progressing or something new is emerging? Any comments on that?
Yeah, thank you for asking that question. I think it's an important question. We do sometimes get slightly indeterminate scan where we do ask to repeat the scan after 18 months. So the minimum gap should be between 18 months to 2 years.
Oh, I see. Such a long gap is needed.
Yes, it is, unfortunately, because if we repeat the scan, even after 1 year, we don't see much difference in the scan. So the recommendation is at least 18 months.
Right. Thank you so much.
Thank you, sir.
Thank you.
Dr. Ambali.
Yes, sir.
Professor Ambali, may I request you for one thing?
Yes, sir.
Kindly thank the learned speaker on behalf of Geriatric Society of India and on our personal behalf.
Sure,
And
sir.
please request him, as and when he is passing through Delhi or coming to Vijaypura, we'll be happy to have him invited for a guest lecture.
Sure, sir. Sure, sir.
Thank you.
Definitely. Yes, sir. Thank you, sir.
So there are few questions on chat box.
So how much is the approximate cost of this?
We do charge about 350, 400 pounds. So I don't know the cost here, how much it is.
Can it predict the response to levodopa?
No. But it helps, it supports the diagnosis in choosing the management. But if you treat the patient with levodopa, if you repeat the scan, it doesn't become normal. It will still stay abnormal.
How do we differentiate vascular Parkinsonism based on plaques?
Yeah, it's a bit challenging. Usually, it can be unilateral. So the vascular Parkinsonism tends to be unilateral. And you don't get the increased background activity. And if we do see that, we do ask for MR or CT to confirm if it is vascular Parkinson's.
Can we give general anesthesia for immobility during this scan?
It's very, very difficult. Very difficult to do the scan, because if you give the general anesthesia, you have to intubate the patient, and the scan has to be very, very close to the patient. We have had these requests in our hospital as well. Unfortunately, you cannot do under GA because the camera will be too far and you won't get a diagnostic scan.
Can the scan help for prognostication?
I would say no. This will help only in initial diagnosis rather than looking at the prognosis. That is based on the fellow of the patient. Okay, thank you.
Thank you, sir, for sharing and explaining.
Good evening, ladies and gentlemen. Dr. Rakesh Sajjan, proud alumni of our institution. Dr. Anand Ambali, Professor and HoD, Department of Geriatric Medicine. Dr. Bentoor, sir, Professor and HoD, Department of General Medicine. And my other colleagues and dear students. Really, it was a wonderful day for all of us, because we have our proud alumni, Dr. Rakesh Sajjan, who is there with us today, who is sensitizing our postgraduate students and other students about the role of DaT scan in the Parkinson's disease. Because we know that Parkinson's disease is a devastating disease, slow, progressive disease, which will make patients dependable on others. And also ultimately, as there is not much active treatment, definitely as the days progresses, patients will become bedridden and succumb to other complications. So early recognizing the symptoms, because sometimes symptoms may be confusing. Patients will have only tremors, whether it is due to Parkinson's or other diseases. Definitely the role of DaT scan is important. So sir has elaborately told what are the indications of DaT scan, what are the contraindications, where to use, and what are the results of that DaT scan. So this will help you for your exams also, because it's a latest tool in the diagnosis of Parkinson's disease. And I also congratulate Dr. Anand Ambali for organizing this guest lecture. Is very active. You know that Department of Geriatric Medicine is very active. It's at a national level, our college, because of Dr. Anand Ambali. And also the other organizers, API, Karnataka State Chapter, and Geriatric Medicine. I thank them for giving me this opportunity to be the guest for this occasion. I thank each one of them. Thank you.
Thank you, sir. As a mark of respect and gratitude, I invite Dr. Rajesh Honnutagi, sir, to present mementos to our guest faculty and our chairpersons of today's program. I would also like sir to hand over the mementos to our chairpersons, Dr. Sanjeev Bentoor, sir, and Dr. Sangamesh Bhagavathi, sir. Thank you, sir. I now invite Dr. Harini T. to propose vote of thanks.
Good evening, everyone. It is a great honor and privilege for me to propose vote of thanks on this memorable occasion. First and foremost, a very special thanks to our eminent speaker, Dr. Rakesh Sajjan, sir, consultant nuclear medicine physician, Central Manchester University Hospital, NHS Foundation Trust, Manchester, United Kingdom. Sir, your talk was truly insightful and comprehensive. It was certainly enriched our understanding and will help us improve patient care. Thank you, sir. I express my heartfelt gratitude to our chief guest, Dr. Rajesh Honnutagi, sir, Professor of Medicine and Medical Superintendent, BLDE DU, Sri B. M. Patel Medical College, Hospital and Research Center, Vijaypura, for gracing this occasion with his presence in spite of his busy schedule. Your encouragement, continued support means a lot to us, sir. Thank you, sir. I also extend my gratitude to our chairpersons, Dr. S.N. Bentoor, sir, Professor and HoD, Department of Medicine, BLDE DU, Sri B. M. Patel Medical College, Hospital and Research Center, Vijaypura, and Dr. Sangamesh Bhagavathi, sir, Associate Professor and Consultant Neurologist, for their guidance throughout the session. Thank you, sir. I would also like to thank all the administrators of BLDE DU, Geriatric Society of India, Association of Physicians of India, Karnataka chapter and Vijaypura branch, Indian College of Physicians for their continuous support. I would also like to thank all the participants, our respected faculty members, postgraduate students and interns for your active participation. Your curiosity and engagement made today's program successful. Lastly, I would like to thank members of Medical Education Unit and IT member for ensuring smooth coordination and flawless execution. Once again, thank you all for your attention. Thank you.
Thank you, ma'am. We now come to an end of today's session. Thank you all for your presence and active participation. The program concludes with high tea outside the medical education hall. We warmly invite everyone to join us.